Hi, Christoph.
Hello, how are you?
Good morning in Germany.
Yeah, hello.
It's so early in Germany right now, right?
Yeah, it's 5:30.
5:30, yes, I know. Well, thank you very much to be this night in Mexico with us. I appreciate your time. And it's a pleasure for us to have you here like a speaker. And with this interesting topic about patients with antiretroviral therapy with viral load suppression. And it's a very hot topic right now because I think some integrase inhibitors are presenting some problems with overweight, with metabolic problems and cardiovascular risk, diabetes. Then I think here in Mexico is very important this topic right now, and I appreciate your time to share with us your knowledge. I would like to introduce you. Hola, buenas noches. Voy a comentar acerca del doctor Christoph Boesecke. Eso es un poco acerca de su currículum. Él completó sus estudios como de medicina en la Universidad de Charité en Berlín, Alemania. Él recibió su doctorado en medicina de la Universidad de Hamburgo en Alemania. Parte de su investigación ha sido en infección aguda por VIH. Él tuvo una posición posgraduada a los 2 años acerca del estudio de inhibidores de integrasa en pacientes con infecciones aguda y crónica, y además se encuentra en el Centro de Investigación Nacional Epidemiológica y Clínica de VIH, ahora es el Instituto Kirby en Sydney, Australia, y él actualmente trabaja como especialista en enfermedades infecciosas y como un ponente de alto nivel en pláticas en la Universidad de Bonn, Alemania. Sus principales áreas de investigación están enfocadas a las comorbilidades y coinfecciones en VIH, particularmente hepatitis aguda. Creo que hepatitis aguda ha desarrollado gran parte de los lineamientos en Europa acerca de esto. Thank you very much. Dr. Christoph. Gran parte de los lineamientos en Europa acerca de esto.
Okay, so many thanks for the kind introduction and the invitation. I really appreciate that you're still around at this time of the day. So it's close to nighttime at your time and very early morning here in Germany. I think I also agree that the topic is very interesting because nowadays that everyone is put on treatment soon after HIV diagnosis, we rarely have any patients left in our department that are still antiretroviral treatment naive. So whenever a new study comes up for HIV naive patients, we really struggle to find new patients to include them in the trials, other than the ones that come through the door with a newly diagnosed HIV infection, because the days that we wait until CD4 drops below 350 are luckily over. I've built this talk around cases, and Antonia has already highlighted some issues that we might touch on. And I think we've got time at the end for some questions. So the usual disclaimer up front with the conflict of interests. So I think when we think about switching ART in patients who are otherwise virologically fully suppressed, so the ART is working, there's several reasons why you could think of switching the ART, and that's an extract here of the European AIDS Clinical Treatment Society guidelines, which I highly recommend. That's one of our main reference documents here in the area. They are constantly updated once or twice per year. You can download them as a PDF from their website or get the app from the App Store. And they came up with a list of 9 points why you could think about switching in ART in a patient who's otherwise virologically fully suppressed. That's number 1, a documented toxicity. Number 2, a toxicity that you would not like to see happen in your patient. Then number 3, the avoidance of drug-drug interactions. Number 4, a female patient who is already pregnant, wants to become pregnant, or wishes to conceive. Then number 5, aging and or comorbidities. And I think there's a large overlap with point 3, drug-drug interactions. Then number 6, simplification to reduce pill burdens for patients who are on still very heavy pill burden regimens. Then protection from hepatitis B co-infection or the reactivation by including or switching them to tenofovir containing ART. Then regimen fortification in the rare cases that you would like to see a stronger regimen to prevent resistance development in patients with adherent problems. And then number 9, which to date is not that much of a problem, at least in Germany here, to reduce costs so that we have to switch patients to generic drugs to reduce the cost of the otherwise, at least in Germany, very pricey ART. And I think if you break it down to clinical life, and hopefully you'll all agree, I think we are talking about 3 main reasons why we switch patients with an HIV infection from their otherwise fully working ART. It's definitely due to toxicities, the ones that you see or the ones that you want to avoid. Then number 2 would be drug-drug interactions, and number 3 is simplification. And we will touch on all these 3 areas throughout this talk. So if you look at cohort data in terms of switching ART, what were reasons for modifying the ART within the first 3 years after starting someone on antiretroviral treatment, and those data are already a bit outdated. And you can see that there are several reasons. The dark blue ones are the ones that are still on their initial regimen. And the good news is, since 1995, the percentage of patients that are still on their initial ART regimen is increasing. And to date, it looks like as if 2/3 of our patients are still on their initial ART regimen. But the other thing that has to be highlighted, and that's why I included this slide, is the portion below in this skin fleshy color, and that's toxicity, and that's rather stable. So if you look at 1995 to 1997, there was around 25% that were switched within the first 3 years due to toxicities, and that hasn't really changed much until the last years, 2010 to 2012. It's still around 20%. So we still have to change a lot of our patients within the first 3 years from their initial regimen due to toxicities. So let's start with the patient. Patient number 1, he's a 45-year-old man. He used to inject drugs, and that's probably where his HIV infection came from. And that was diagnosed in March 2000 at a rather early stage, CDCA1. And he was also diagnosed with a hepatitis C genotype 1b infection at that time point, and already had a history of depression at that time. So then the guidelines were still different, so there was no need to put patients on ART rather soon. So we watched the CD4 count and did all the other assessments over the years. And in February 2015, there sort of came the time point to put him on ART. We discussed with him that the hepatitis C co-infection alone would be a reason to start ART rather soon, but he was very, very hesitant to start treatment. He had read a lot and was very worried about side effects, pill burdens, etc. And that was also the reason why at that time point he rejected hepatitis C treatment with interferon, ribavirin. So he was still virologic for both of these diseases in 2015, but then agreed to start ART with dolutegravir, abacavir, and 3-TC. And we were also discussing, because data were coming up of the DAA treatment options in hepatitis C, to at least plan his hepatitis C treatment. We did that 2 years later in 2017, and he was successfully cured of hepatitis C. It was a very good moment for both sides in the clinic, the patients and ourselves. And then following that, he complained about the reappearance of his depressive symptoms. He already had contacts to his previous psychotherapist, which he saw rather soon, but that actually had no effect. And you remember he was very worried about side effects of pills, and he still refused to take any antidepressants. And the situation actually got worse, and both of us, he and myself, were actually fearing that he might go back to injecting drugs because it was rather unbearable. And at that time point, you might remember there were data coming up of CNS toxicity signals for the class of the integrase inhibitors, and particularly individual agents. And those are cohort data here from Germany from our colleague Christian Hoffmann. And those have also been published in the meantime. And they have 2 large clinics in Hamburg where they looked for CNS toxicity symptoms in their integrase treated patients. At that time point, there wasn't really a substantial amount of patients on bictegravir, so they only could compare dolutegravir, elvitegravir, and raltegravir. And you can clearly see, if you move down to the bottom of the table, the rates of insomnia and sleep disturbances, poor concentration and slow thinking, dizziness, headache, and depression. Those events were more likely to occur under dolutegravir when you compared it to elvitegravir or raltegravir. And they had a follow-up analysis to look for factors that were sort of associated with that. And they found that female patients were more likely to develop these problems, and also elderly patients above 60 were more likely to get CNS toxicity signals under integrase inhibitors, and in this case, particularly dolutegravir. If you want to know what's happening with bictegravir, because then at some point Biktarvy was licensed as well, and there were several switch studies that were included into the licensing portfolio. And that's the 1844 study here in suppressed adults that were switched from Triomec or stayed on Triomec. And you can see that the drug-related or grade adverse events were higher for the Triomec arm in to the right of the table. And that's actually quite astonishing, because what you usually see in switch studies is patients who are switched away from their current regimen and move to the new one usually numerically have more adverse events just because you changed their current treatment, and something always happens when you change treatment. But in this case, it was the other way around. The ones that stayed on their initial treatment actually still had more drug-related or grade AEs than the ones that were switched to the new regimen. And that's particularly true for the CNS signals, but also for GI upset and other adverse events. So Biktarvy seems to perform a bit better in terms of the CNS signal, and the company came up with a very fancy sort of comparative, colorful new way of presenting data. And they had a look at which time point the adverse events occurred throughout the study, and this is up until week 48. And if there was any trends towards one of the 2 regimen, and the boxes in green show you when the events that occurred were significantly different in this time in favor of Biktarvy. So there were differences in a lot of areas, and that also included CNS, the CNS system, with nervousness and anxiety, feeling sad, down and depressed, dizziness and lightheadedness. And the point I would like to highlight is that these events also occur a year within the study. So that's also something that occurs on the long run, particularly ones on Triomec, because they had been on treatment before already. So what did we do at that time point? we thought it's no use to switch him off the class of integrase inhibitors, because he was not really very much a fan of more pill regimens. There were only a few single pill regimens available at that time, so definitely a tripler was not an option with the strong CNS signal for efavirenz. So we talked about him and said to him that there's one new pill that might be doing better. It's still the same class, but apparently the CNS signal seems to be different. And we gave it a try and switched him to bictegravir FTAF in September of 2018. And really over the month that followed, the CNS systems got better. They're still there. He's still seeing a psychotherapist, but they sort of have at least weakened over the month that followed the treatment switch. And what we have learned from this case is that the CNS toxicity is nothing that can come up early on, but that can also be a long-term toxicity that pops up after 3, 4, 5, 6 years when someone is on a stable regimen that's from virologic perspective fully working. So the second patient with one of the other toxicity topics that Antonio already alluded to is highlighted in this patient. It's a 48-year-old MSM. He was diagnosed with HIV in 1993, already with a slightly advanced HIV disease with CDCB3. He was put on ART in 1999. At that time, one with 2 pills, efavirenz, and 2 NRTIs. And when a tripler became available in 2007, he was put on the fixed dose formulation. And since then, he has also suffered from one comorbidity, that's arterial hypertension, which is not that easy to treat. So at the moment, he's on 3 antihypertensive drugs, ramipril, amlodipine, and bisoprolol. That all went well. He was taking his treatment regularly. The CD4 T cell count was good, viral load was suppressed, so everything went well. And in August of 2018, he complained for weight gain of 10 kilograms, and he was then at 99 kilos with a height of 182 centimeters. But there clearly was a reason. He was actually quite happy because after decades, he had managed to stop smoking. That was something that we discussed regularly over the years, including particularly with a focus on his subarterial hypertension and the metabolic syndrome that might pop up at some point. We try to see our patients every 3 months, so 4 times a year. So he came back in November 2018. His weight was stable. And at that time point, we had a discussion again, as we had over the last years, that the signal for efavirenz with the CNS toxicity was still quite strong. We had the experiences that even patients that were doing well when they were switched off efavirenz, they were doing better in terms of dizziness and concentration, and particularly in terms of sleeping undisturbed, although they weren't really complaining about this while being on a tripler because they had been so long on efavirenz. And also with the arterial hypertension, and now in elderly gentlemen, we thought about taking him off TDF and putting him on TAF to avoid fueling his metabolic syndrome. And we switched him to bictegravir FTAF, and he then came back in March 2019 and was really not that happy because he had gained even more weight without really changing anything, and he was now at 112 kilograms. So that was already visibly clear when I picked him up in the waiting room that there was an additional change in his weight. And you're aware that was around the time where the first cohorts reported an increase in weight in patients on integrase inhibitors. And at that time point, there wasn't really clear what was going on, but there was the CROI conference last year, where the first cohorts really showed some impressive data. So I picked out one because that was one of the cohorts that was presented in the oral abstract session, from the North American cohort, which is always good for various analyses in the past and will probably do so in the future. And they could clearly show an increase in weight in the classes of the integrase inhibitors, much more than when you compare it to protease inhibitors or NNRTIs. Over the first years, shown here that is 5 years after starting an ART regimen. And if you focus on the classes of integrase inhibitors, the effect was most prominent in patients on dolutegravir compared to raltegravir and abacavir. Already at that session, I very well remember that Andrew Hill from the UK stood up and said, look, you can't, nowadays you can't look at drugs individually because most of our patients are on single tablet regimens. And that usually is a combination of 2 or 3 ARTs. So what was the backbone the patients were on? Was there maybe also a change or switch to or an initiation of TAF containing treatment plus integrase inhibitors? So at that time when there was already very discussions if it's really related to one class or 2 or something else. And then, of course, several cohorts reported also data, and the companies also looked at their licensing trials to compare weight gain. And everyone started to focus on the combination of integrase inhibitors plus TAF. And you can see here the Gilead and ViiV studies that were investigating dolutegravir or bictegravir plus minus TAF. And then the strongest signal came from the advanced trial shown to the right, where they really saw a significant weight increase in patients receiving dolutegravir plus TAF compared to dolutegravir plus TDF, or compared to patients that didn't receive an integrase inhibitor at all plus TDF, in this case a tripler. And that study was mainly done in Africa, and that was particularly true for the female participants of the study. So the signal is really clear and strong. It's the combination of integrase plus TAF that seems to lead to an excessive weight increase in a subset of our patients. That, of course, caused some concern within the staff of the manufacturing companies. And Gilead very early on did an analysis of their 7 licensing trials and came to the conclusion that the most novel finding was, again, the association between weight gain and the type of ART. And they've also found the association with the drug class, again, favoring the integrase inhibitors versus NNRTIs and PIs, and also favoring specific ARTs, and in this case, bictegravir and dolutegravir performed worse than abacavir. Rilpivirine did better than efavirenz. TAF did worse than abacavir and TDF and AZT. And they also stated that overall the greater weight gain was observed among newer antiretroviral agents when it was compared to the comparator treatments. So what did we do? The patient was really unhappy. There was no way that he was continuing the treatment because he was really linking it to the switch in his ART regimen. And when we then had a lengthy discussion and thought, well, the data is so clear at the moment, we don't really have a patho mechanism that explains what's happening with integrase plus minus TAF in a certain subset of patients in terms of fat development. And then thought, well, if we think that the combination is causing a problem in this individual patient, then it's probably sensible if we take him off integrase inhibitors and also TAF, although we are aware that he's now approaching 50 years and suffering from arterial hypertension, and maybe TDF isn't that much of a good option on the long run. But just to really get an idea if the switch into ART was contributing to his weight, we then discussed with him that we could put him on the newly licensed NNRTI doravirine, which is available in a fixed dose combination with 3TC and TDF. And he instantly agreed because he was really unhappy with his weight gain. And we switched him to Delstrigo. And when he came back later in May of 2019, his weight went actually down to 102 kilograms without really changing anything in his diet or exercise. So again, that this highlights there really is in clinical life a signal for weight gain with integrase inhibitors and TAF. On an individual basis, I can't really say that everyone who has been put on integrase plus TAF in the recent years has excessively gained weight. That's not true either. But I think you would agree that there's a certain amount of patients in our clinic that, due to whatever reason, any interference on the level of the adipocytes, going back to integrase plus minus TAF, that might lead to an excessive weight increase, and then needing a switch in the ART to sort of get away of this drug toxicity. So the third patient that we discussed today that will touch on another area of reasons for switching ART is 58 years old. He's a former IVDU. He was diagnosed with HIV in 2008, also at a CDC stage B3. He also has a Hep C infection, 1B, and as it occurs very often, he's a very committed smoker and has already accumulated around close to 60 pack years. Due to his Hep C infection, as discussed earlier, we really said to him, look, that's already one reason to start an antiretroviral treatment regardless of your CD4 T cell count, and he was quite happy to start ART. Was put on TDF-FTC and boosted darunavir in March 2008. At that time, but of course, there was no fixed dose single tablet regimen with darunavir available. He was also cured of hepatitis C close to a decade later in 2017. He was also not keen to try interferon ribavirin. He had a lot of friends who did that and really didn't do well, and in the end didn't even clear the Hep C infection. So he said, look, I'm going to wait. I'm happy to do the HIV treatment, but I'm not going through the dreadful Hep C treatment. And the decision was right. So when the DAAs became available, we were rather soon able to cure him of his hepatitis C infection. HIV was very uncomplicated throughout the years. He was switched at some point to the STR of darunavir boosted with cobicistat and then FTAF. And in 2019, keeping in mind that he still was very committed to smoking, he suffered from an arterial embolism in his left leg, was seen by the vascular guys, and he was diagnosed with a rather severe peripheral artery disease. He received a PDCA, and following that a stent. And of course, what happens then is that whenever our patients see a cardiologist or a vascular specialist, they come back with at least one drug that is supposed to thin their blood, and this guy came back and had been put on clopidogrel 775 milligrams per day. And he just mentioned this, by the way, at one of the routine follow-up visits. And I think that's one of the more time-consuming elements nowadays when you see otherwise healthy HIV patients, our aging patient population. And this is also reflected in the newer EACTS guidelines. They included a section on prescribing in the elderly HIV patient with age-related comorbidities leading to polypharmacy with the risk of drug-drug interactions, and then also age-related physiological changes that over the years can impact the pharmacokinetic and pharmacodynamic effects of the drug, and that might lead to inappropriate drug use or inappropriate drug levels in the blood. And as a result, you can really come up with an increased number of adverse drug reactions that can lead to non-adherence, cognitive impairment, impaired balances at falls, and they really then lead to higher morbidity and hospitalizations. So what we all include in our clinic is to sort of periodically perform medicine reviews, and I've asked my patients every time, so 4 times a year, if there were any changes in his other medications, if he's taking anything at all in addition to his HIV medicine, just to get an idea, were there any health issues in the last 3 to 6 months? And then you, of course, have to discuss with your patients, is there a need for this additional drug? And what actually happens with the ART treatment when it's taken with other drugs. So just to give you a short overview, what's happening here in Germany in our clinic. So at the moment we're seeing about 1,200 HIV infected patients in our department. And over the years, as you can see, very luckily, as an effect of the modern ART, our patients survive much better than they used to do in the 90s. And at the moment, the percentage of our patients that is 50 years or older is approaching 50%. So half of our patients in our clinic is already 50 years or older. So really forcing us to take care of other diseases more than the HIV infection, and the focus sort of shifts a bit away from the rather dreadful HIV management in the 80s and 90s, and now focusing on other diseases, comorbidities, and also co-medications. And that's, of course, not a local phenomenon. That happened at every HIV clinic on the planet. And this is data from the US HOPS cohort. And they were very keen to show that, of course, when the HIV patient ages, you've got also an increase in comorbidities that you see in everyone on the planet, but particularly so in the HIV-infected patients, and that's hypertension, dyslipidemia, psychiatric illnesses, chronic kidney disease, cardiovascular disease, as is the case with our patient, diabetes, and other chronic diseases. And that sort of really seems to kick off around the age of 50. And when you compare patients with an HIV infection to HIV negative members of the population, then you can also see that the comorbidities are the same, but the age where they become prevalent is different. So the distribution that you see here for 0, 1, 2, or 3 comorbidities in the blue colors in the HIV infected population, when you look at people being 50 to 55, you can find the similar distribution to the right in the HIV negative controls in the group, let's say 55 to 59, or even 60 to 64. So not only do our HIV infected patients seem to have more comorbidities, but they also come at an earlier age, 5 to 10 years earlier, which should really affect our screening endeavors when we see our patients. And that's data from Germany, from the Boesecke cohort. And they also had a look of the comorbidities that come up over the years, again, to illustrate that sort of the cutoff age really seems to be 50 years. So at that time, when then 1/3 of the patients that were in this cohort were already suffering from 4 or more comorbidities that were not related to the HIV infection, and of course then resulting in significant co-medications. And this is a sort of a numerical calculation, what happens when you increase the pill burden you are taking. And if you have got 4 additional comorbidities, it's very likely that you will at least end up with 3 or 4 additional more pills. And you look at the table, then the number of possible combinations and interactions is 11, and if you're on 5 pills, it's 26. So the more pills you're taking simultaneously, the much higher exponentially the likelihood that you will end up with any interaction that might impair drug levels and then really impede your treatment success for HIV or for the other comorbidity that you would like to see controlled. And that, of course, is not that new, at least since the introduction of protease inhibitors. We're very much aware of the potential drug-drug interactions with antiretroviral treatment, and of course the EACTS guidelines also do include several tables. That's a very broad overview, looking at interactions between antiretrovirals and other drug classes, CNS drugs, cardiovascular drugs, anti-infectives, and mixed drugs. But what you can see clearly if you just look at this table from a distance, so green is always good, and you can see that the NRTIs seem to be quite okay when it comes to interactions, particularly FTC, 3TC, and TAF, and also the classes of the integrase inhibitors seem to be doing okay when it comes to interactions, particularly bictegravir, dolutegravir, and raltegravir. Abitagravir is not that good because you remember it's boosted by cobicistat, and the booster, of course, can cause problems in terms of drug-drug interactions. So what do? You definitely have to check for drug interactions whenever your patient mentions that he has been put on a new drug. In the case of our patient, he has been on Zymtuza for quite some time and has been now put on clopidogrel to keep his stent open that he received for his arterial clotting. And the website we use is the one done by the University of Liverpool, HIV drug interactions.org. And when you dump in Zymtuza to the left and clopidogrel, you get a red flag and comes that you shouldn't co-administer it. The ritonavir booster really is an issue when it's combined with clopidogrel and leads to significant drug-drug interactions and plasma level changes. So what did we do? We discussed with him that at the time, for the moment, there's no chance of getting him off the clopidogrel because there's a high risk that his stent might clot, and then he's got the same problem again. So we talked to him and said that he has to get rid of the boosted protease inhibitor and should maybe be put on an integrase inhibitor. And then we were also thinking about sort of modernizing his NRTI regimen, and were thinking, if someone who has been virologically suppressed for so many years, is there really a need in someone who is sort of facing apparently several comorbidities? The arterial disease will not be the only comorbidities that he will have to live with in the next 5 to 10 years, I'm very sure, keeping his heavy smoking history in mind. And we then thought, does he really need 2 NRTIs to really keep the virologic success he has been having over the last years? At that time point, the new STR with 2 HIV agents, dolutegravir and 3TC Dovato, became available, and we thought we'd give it a try and put him on the 2 drug regimen, integrase based, and he was still fully suppressed 4 weeks later with 317 cells, and viral load wise also below the threshold of detection, with which is at our lab at the moment 40 copies per ml, and has been doing so ever since, and is doing very well with his 2DR. So the last area that has to be touched when we talk about switching AIT is the topic of simplification, and I think I put this at the end because at least in Germany, what can happen is that sort of the patient perspective is lost in the medical battle around pills and everything else, and we sort of tend to not ask our patients how he actually feels, how he's doing, and what his concerns are regarding his antiretroviral treatment. And that's one of the more recent surveys that I could find that was done in Germany and people living with HIV. And what came up as number 1 on the list in wishes for an ART regimen change was that they would like to reduce the long-term effects of the HIV medicine on their body. And they were also very keen to take something that's longer lasting, so they could take their treatment less often with the same virologic effect, fewer side effects, which is already touched on with the long-term effects. And also I can take less HIV medicine, so less agents, and get the same effect. What was not that important, quite surprising, at least for the practitioners in Germany, that the food restrictions and requirements were not really seen as that much of an issue, and also not the pill size. In other cohorts, this has been reported as really as a serious issue, pill size. So that's an anonymous questionnaire that was done in the US, and they found a relationship between pill aversion symptoms and the adherence of the medication, because that can really lead to patients not taking their pills at every other day. And in this analysis, they found that patients that were complaining about the size of their HIV pill, or that were complaining about nausea, the feeling that the pill gets stuck, or the taste of the pill, were more likely to skip their pills, whereas the other ones didn't. So that really is something to also keep in mind and ask the patient, particularly in the ones who have subtle blips, if they are really fully adherent, and if not, what the issue might be. Is it related to nausea, size, etc.? And that's a comparison. At the moment, I don't have anything else, just to give an idea that our single tablet regimens are clearly different in color, but also in shape and size. And there are really some pills that are quite large, and some patients really struggle to swallow these. And then there are ones that they're much smaller. At that time, Dovato wasn't available, but if you want to include it, it's also a very small pill and could be put close to the Biktarvy pill to the left. So just as a reminder, not every STR is sort of similar. There's really an issue in terms of size and swallowing and tolerance. So what's the issue with our patients? So we very much focus on virologic suppression, and that is given in the setting of this talk. You all are aware of the 90-90-90 targets. So the 90% of our patients should receive their diagnosis. Of those, 90% should be treated. Of those, 90 should be below suppression. And I could tell you that in Germany, we are doing okay with the second and the third 90, but we are at the moment not really reaching the 90 in terms of diagnosis. So at the moment, 89% of HIV people living with HIV in Germany know of their diagnosis. So even we still struggle with 390s. And if you look at it globally, 73% of treated patients are suppressed. So, but I just included these targets to highlight that there was a group of physicians that came up with a sort of additional definition to the 90-90-90 target calls, and that's something that's beyond viral suppression of HIV and leads to quality of life. And they said that they would like to highlight or include a fourth 90 to this cascade. Because the strategy so far does not provide targets for the concept of ensuring healthy lives and promoting well-being in people living with HIV. And that's why they proposed adding a fourth 90 to the testing and treatment target to ensure that 90% of people with viral load suppression have a good health-related quality of life. And they also came up with a very lovely figure with a fourth 90 to the right, symbolizing the good health-related quality of life. And then in addition, they also suggested that health-related quality of life for people living with HIV also should attain attention to additional domains, comorbidities, and self-perceived quality of life. So the patient is really asked to tell how he thinks his quality of life is, and no one else. And that sort of alludes to the issue that was raised in the question as well, because we see more and more patients who are struggling to take their daily pills after 20 years of HIV treatment. And we are very much looking forward to the first HIV drugs that will be licensed hopefully at the end of this year. The company, the manufacturer, has submitted the documents early on this year, and they had to do some homework, and I think they will receive hopefully licensing at the end of the year. And that's the intramuscular administration of an integrase inhibitor plus ripivirine, and that for a fraction of our patients really will be, I think, a change in an improvement in their quality of life, because we still have a lot of people who are only on antiretroviral treatment, and that they can then live a pill-free life, and that also will relieve them of the stigma issue and being reminded every day, every morning of their HIV infection when taking their pills. And if you look at one of the trials that were done for the licensing purposes, you can see that all study participants, women, men, and overall that were randomized to the intramuscular treatment arm, were much more satisfied with their treatment option than the ones that stayed on their oral antiretroviral treatment. So I'm very sure that our clinic at least will change within the next 6 to 12 months, when for the first time we will have an antiretroviral treatment that hasn't to be taken orally every day, but can be injected intramuscular, hopefully every 8 weeks. So with that, I would like to come to an end, so we have some time left for questions. So I think the reasons for switching ART are 3 large areas and domains. Number 1 is drug-drug interactions, particularly with increasing comorbidities in our aging patient population. Then the issue of toxicities, side effects, short and long term, but also avoiding toxicities during pregnancy. And we have been told in the last 2 years that every drug might end up with a new toxicity signal at some point. So we need to remain vigilant and need to listen to our patients who are complaining about new things that might not be some individual issue, but might really allude to a new toxicity signal. And then, of course, simplification or other ways of administration to reduce pill burden and to really focus on the fourth 90 and improve the health of people living with HIV and their quality of life. So thank you. Last thing, please keep in mind, sorry, that's what I included before I went to bed, 2 points to consider. So the setting is virologically suppressed, but when you take someone off the ART, please remember to check if you've got a resistance test available, so that you don't put him on a drug class that he might have an archive resistance. And please, particularly if you move them to the 2DR drugs, please check for hepatitis B co-infection, so you're not losing control of the Hep B infection when you switch someone off TDF or TAF. So that's it. Thank you.
Thank you very much, Dr. Christoph. I think there are some questions, and while we wait for physician questions, I would like to ask you about the first case that you presented. Regarding that, dolutegravir, TrueMeg was presenting neuropsychiatric adverse events in the first patient. I have 2 questions regarding the data of your colleague Christian, who presented it in 2 papers. The first one is abacavir is a risk factor when it's combined with dolutegravir to present neuropsychiatric adverse events. Do you think that if you change TrueMeg for Dovato, would be a good choice? What do you think or do you think that dolutegravir continue with the same problem with the neuropsychiatric adverse event?
I think it's a very good question, and I completely agree. That's what we saw in our clinic as well. The ones on TrueMeg did much worse than the ones that were, for instance, put on dolutegravir plus Descovy as a single pill TAF FTC. I think the signal for CNS with the integrase class has always been there, and it seems to be more prominent for the 2nd generation integrase inhibitors. But to date, the number of Dovato patients is too low to really see if there's an improvement. I would agree that people who are switched off abacavir, I would assume that there's an improvement, definitely, because it's a combination effect. There's something that abacavir does in addition to dolutegravir. But I would assume that the signal sort of remains if you're still on dolutegravir, and even Biktarvy has CNS toxicity signals, if so, to a lesser extent.
Thank you. Thank you, Dr. Christoph. My second question is regarding the same clinical case. Dr. Hoffman presented in the last paper that Trumec and Biktarvy will be presented the same adverse events regarding neuropsychiatric problems. Then when you change Trumec to Biktarvy, do you think the neuropsychiatric problem will be maintaining in the patient? Do you think doravirine will be another good choice in this case?
So the problem, let's say, with the Hoffman data is that the Biktarvy numbers were not high enough. So that because it was newly licensed, and the numbers are not that high when you compare to the ones that are on dolutegravir. So we in our patient ended up to take him off integrase completely just to get a clear idea. So if you think there's some impact of the integrase inhibitors on the CNS system, I think we have enough drugs from other classes that are very tolerable, very effective, available as an STR, and I would at least give it a try and take them off integrase completely to really get an idea, at least in the ones that are complaining of really serious toxicity signals. I'm not talking about a headache every fortnight, but there really are ones that have insomnia, they have abnormal dreams, they complain of headache every day, particularly the ones on Triomec. There are a few who complain of headaches with onset two hours after pill intake, so there really is a clear correlation. But what I would say, if you think that there's a CNS problem and every integrase inhibitor has it, then why not go for the full change and put them on another class and see how that works. WHO recommends integrase inhibitors as first line, but you know they don't recommend to keep the patients on integrase if you end up with the toxicity. So at least we have some freedom in switching.
Thank you, Christoph.
Dr. Boesecke, I'm Geser Lezama. Nice to meet you. Congratulations for your great talk. And I want to talk with you with something that happened here in Mexico. In 2019, a new paradigm in HIV treatment where integrase inhibitors became the first line of treatment in our native patients. And the government originally proposed an extended use of dolutegravir. But a couple of months later, Biktarvy won the tenders and becomes the new extended use drug. And in that transition period, many patients and organizations, civil organizations, do not look favorably this change. And many patients came to our office with a high amount of adverse events related to this change to dolutegravir to Biktarvy. And I think that it could be a pill aversion phenomenon, like you said in your talk. But the thing that Dr. Mata said related to the adverse event in neuropsychiatric symptoms with dolutegravir and Biktarvy, and the report of Dr. Hoffman that he said that there is a low correlation or cross intolerance between dolutegravir and Biktarvy. What do you think of that? Is a specific adverse event related to molecule, or what do you think about that?
I would agree so, because if you look at the chemical structure, Biktarvy is very similar to dolutegravir. So it's, I think chemically it's 99% the same, and Gilead only managed to, change 2 or 3 side chains. So in terms of pharmacology, which I'm definitely not, but it makes sense that you come up with the same issues. So that's why we are also very cautious in someone who suffers from a CNS toxicity to just switch them from dolutegravir to Biktarvy or the other way around, because that doesn't really solve the problem on a chemical level, because you're just, you're exchanging the green Volkswagen Golf for a red Volkswagen Golf, but you still end up driving a Volkswagen Golf. So that doesn't really change the problem a lot. I'm very curious to see how the 2DR will play out in our area that we just alluded to with the Dovato. So the integrates with only 3 TC. We have to keep in mind that most of patients who switch, and that's something I think we should always tell them in clinical practice, particularly the ones, I have several patients who always want to switch to the newest drug because they read it in the newspapers, and the new ones are always the more fancy ones. So as soon as everything is licensed, they get a new appointment and they want to be switched immediately without any problems in terms of viral loads, CD4, toxicity, whatever else. And so always have to highlight, if it's working well at the moment, you might end up with new adverse events toxicity to just keep in mind. And that's what most of the studies show us. The ones that are switched to anything new, whatever it is, however powerful it is, they always end up with more adverse events, at least in the short course of one or 2 years. So that's a bit of a conservative caution note.
Thank you. I don't know if there are some other questions, Dr. Mata.
Yes, there is another question. What happened with TAF? Because I think if we combined TAF with dolutegravir, patients gain weight. TAF with Biktarvy gain weight. In the second clinical case that you presented, you mentioned that the patient with change to Biktarvy, he gained weight, I think 10 kilograms, more than 10 kilograms in 4 months. Mm. When you change to doravirine in 4 months, he lost weight, I think 10 kilograms. What is happening there? What is the mechanism that you think the patient are gaining weight with TAF, or especially that you presented with Biktarvy in your second clinical case?
So I think the weight gain really is a critical issue, and it's still not solved, at least to my idea. It's not a very frequent problem, so it's not like as every second patients come in and has gained 15 kilos or 20 kilos or more, but there are some patients who I truly believe that they haven't changed anything in their exercise and their diet. We're talking about pre-corona, so within the corona quarantine, everyone is put on weight, but in the pre-corona area, I really have several patients who I really believe they haven't really changed anything. So I think what we need is really a signal on a molecular level telling us what's happening, similar to the abacavir story. So as with the platelet coagulation thing. So as soon as someone comes up and says, look, the combination of integrates and or TAF increases or decreases any receptors on adipocytes, leading to an increase in fat cells or volume, whatever else. And I think they're accumulating data that shows some sort of interaction with TAF integrase regimens on the really molecular adipocyte level. Until then, it still remains a bit speculative, because all our cohorts suffer from the fact that everyone ages and everyone puts on more weight. That's just, the normal thing that happens in life. But again, we have several patients who put on excessively more weight, which they haven't done within the first 10 years of their antiretroviral treatment. So there really seems to be something. And if you look over the history of HIV treatments since the mid-80s, at some point, every drug or every drug class sort of became a red flag for certain toxicities. And apparently weight gain and whatever interference on the insulin or adipocyte level seems to be something that will be attached to integrates and TAF. But for the time being, the only option I see is to give it a try and take them off TAF plus minus integrase. Now that we have Dovato available, we might also give it a try and just, sort of downsize them to dolutegravir 3TC, see if that works, if you separate the TAF from the dolutegravir, or you just take them off integrase also completely and then switch them, for instance, to doravirine. Although I have to say, even within the doravirine studies, were the ones that stayed on the comparator drugs and the ones that were switched to TDF and doravirine, there were also signals of weight increase. So it's not that doravirine is the cure for weight gain. So keeping that in mind, but if you think that there's a problem, then of course you should give it a try. And now we've got a lot of options with very otherwise tolerable drugs, so that people don't really need to suffer from toxicities as they had to in the 90s, just for the pure aim of survival.
Yes, sure. And my last question regarding your second clinical case again. In Germany, I don't know, but here in Mexico, we had a problem with the diet. A lot of carbohydrates, tacos everywhere in Mexico. Then the overweight is most common, I think, than in other countries. But in Germany, do you have a target that the patient is gaining weight 5 kilograms, 8 kilograms? How do you decide to change a regimen regarding overweight, regarding a patient and is gaining weight? Do you think body mass index will be the best choice to decide? Gaining in kilograms, I don't know, because I think it's very important to decide, but when to change regarding only overweight.
Yeah, it's a very good question. So there's no cutoff in terms of kilograms where we say, look, now you've reached 11.5 kilograms, we have to do something. So if you keep in mind that everyone is allowed to gain 1 kilo per year, so maybe that's sort of rule of thumb, but usually the beauty of at least HIV care in our country is that you see your patients regularly, and you can really tell who is the one that has just gained a little bit of weight because he had to stay home office, etc. And the ones that really excessively gain weight. So that's 10, 15, 20 kilograms within a short time frame, so less than 12 months. So there really seems to be something. And then, of course, if the patient really severely complains, not the ones that are sort of giggling and, touching their belly, but the ones that really say, this has never been the case. I haven't really changed anything. This is really molesting me. And if you then get signals for that you're heading towards metabolic syndrome, so the glucose tolerance goes down and the blood pressure apparently maybe not that perfect, so then I think you're really at a point where you should sort of think about switching at least the ART to give it a try if that is also doing something in terms of weight gain. But again, there's no clear cutoff, not yet.
Thank you, Christoph.
And my last question, Doctor, and in the case that you need to use tenofovir in your regimen for certain patients, do you feel comfortable with the long-term security of TDF related to TAF?
So that's so when TAF became available, we were very keen to sort of, without even thinking, put everyone on TAF, and I think the pendulum is now sort of swinging back. And that's heavily supported by our PrEP patients. So no one of us has any problems putting someone on TDF who wants a protection against HIV. And that were the concerns of the licensing authorities as well, that you put someone on an otherwise toxic drug. And if you look at the hepatitis B guys, where they use TAF for the treatment of Hep B, they have certain stipulations when you should use TAF and who is still safe to use TDF. And they have a list of 3 or 4 criteria. One is you have to be above 60 to be switched to TAF, or you should have a kidney impairment, eGFR, I think below 50, when you should switch someone from TDF to TAF, or any other cardiovascular disease. So they are still very keen to use TDF. And I'm a bit more relaxed as well. So if I don't have anyone who's got a metabolic syndrome, I think it's fair, and if he's still well below 60, I think it's still fair to put him back or put him on TDF, keeping in mind that within the next 5 to 6 years, we will have new treatment options where we might probably not even use NRTIs completely anymore. We will inject things, there will be long-term formulations for subcutaneously, etc. So just because you put someone back now on TDF doesn't mean that he will end up with 20 years of additional TDF exposure now. And plus, so my criteria in clinical life is, and I don't use it in heavy smokers because they've got a high risk for osteopenia. And I think then TDF does something to them. So if I've got an even young patient without any comorbidities, but if it's a young MSM and the smoking rate is quite high in our patients, if he really is a dedicated smoker, and even if he's 35 or 40, I would be more hesitant to put him on TDF for the next 10 years, because that, at least to my thinking, is an additional risk in terms of bone health.
Thank you. Dr. Mata, ¿cerramos o qué hacemos?
Yeah, you need to go to bed.
You understand very well Spanish, I think.
I used to live in Tenerife for 4 months while studying, but I've forgotten a lot of my Spanish. Very unfortunate.
We need to go to bed and you need to go to work.
Yes. Trabajamos, sí.
Well, we will see you, I think, in our meeting, our Congress in Sydney, when we are waiting for you, very excited to have you here in Mexico. And I think in November, we will continue discussing so much topics interesting.
Perfect.
Thank you very much, Dr. Christoph. Thank you today for your support in medical education. Now with the collaboration with SIDBI, I appreciate so much that you are available to share your knowledge with us.
Mm-hmm. Perfect. Buenas noches.
Thank you.
Bye.
Buenas noches. Auf Wiedersehen.